So to start, I have no disclosures. There are a couple slides on obeticholic acid, which is not FDA approved for the treatment of NASH. And I'll go over what my objectives will be today. So hopefully I will talk about the epidemiology and natural history of this disease. One thing that I think might be useful would be to outline an algorithm for identification of disease and management of patients who have it. I do have some things to say about fatty liver and liver transplantation, including rates of transplant and some outcomes. And then I will talk about treatment options for fatty liver disease, both pharmacotherapeutic and other. So some epidemiology first. There's always a lot to say about the epidemiology of fatty liver disease because my main job right now is to show you how prevalent this is. It's shocking how prevalent this disease is. So this is what the slide of a fatty liver biopsy looks like. This is the H&E stain of steatosis. And this would be the broadest category of non-alcoholic fatty liver disease. We think that let's get to the end here. We think that about a quarter of the U.S. population has fat in the liver that would constitute fatty liver disease. The majority of those are not from alcohol, and so we think that between 20 and 30% of patients in this, of people in this country have non-alcoholic fatty liver disease. That's a huge number, and that gets you right to around 70, 80 million Americans. Now I'll show you in a few slides that it's really not that much different in the rest of the world these days. It may have been 20, 30 years ago, but not anymore. This next slide here, you can see the rim of it here. Now there are little blue cells. Now there's inflammation in the liver, and therefore we call it NASH. We think that NASH is present in about 10% of patients who have NAFLD, non-alcoholic fatty liver disease. So one of the big take-home messages here is that even though a lot of people have fat in the liver, those who are at risk for liver disease is lower. It's about 10%. And of this 10%, a fraction, maybe another 10%, will progress to cirrhosis. And these are the ones that we need to see in liver clinic, but these are the ones we really need to find. Unfortunately, about half of these, similar to in hepatitis C, about half of these are undiagnosed and asymptomatic. So maybe 20, 30% of the time when I see a patient for the first time in the office for fatty liver disease, we sort of together realize at that moment that they have cirrhosis already. NASH HCC is growing. It's prevalent, and we see it here as a referral center, a transplant center. It's not common. 4,000 cases a year out of about 30,000 cases a year in the U.S. Now, HCC is one of the fastest growing cancers in the United States and one with the highest mortality, but that's still a minority of cases. And so you have a real drop-off here in incidence between NAFLD, NASH, cirrhosis, and it really drops off for cancer. Hep C is still by far the main reason for liver cancer in the United States, and it's actually still the fastest growing. So what we're seeing is a delay in treatment of hepatitis C, ramping up of this fatty liver cohort, and we're probably, 5, 10 years away from seeing these types of numbers change. So who gets fatty liver disease? So I'm going to quote this study. This was done 10 years ago now in the East Bay, Kaiser East Bay, 4 hospitals, Pleasanton, Fremont, Hayward, and Oakland. And it's a nice study. It's very simple, and it illustrates a point that there is unequal ethnic distribution in fatty liver disease. So, for example, they simply described the ethnicity of their entire cohort, which is the black bar, and then they defined, as I've written here, they defined fatty liver disease, either biopsy or ultrasound, and said, what's the ethnic makeup of the fatty liver group? And what you see is that Caucasians are 59% of the cohort, but 45% of the fatty liver cohort, they are underrepresented. You see that Hispanics are only 10% of the entire cohort, but 28% of the fatty liver cohort, they are overrepresented. Asian Americans it's more or less equivocal. In fact, they're overrepresented in the fatty liver group as well, but not by as striking a difference, and it's a smaller number. And the other thing to point out here is that African Americans didn't make up much of the cohort, but they're also underrepresented, and I'll get to that in just a second. just for the purpose of comparison, we also looked at our the ethnicity of our patients. So I've added a bar here in red, which is the breakdown of the CPMC fatty liver patients or cohort. You'll note that there are even more Caucasians in our group. So that doesn't actually reflect the ethnic makeup of our San Francisco patients, but in fact, I think emphasizes the fact that a lot of our practice is outreach, and that this is places like Eureka, Fresno, Modesto, where the patient population looks very different than it does here in San Francisco.
So, well, did that study control for other causes of liver disease?
So it was retrospective, and so yes, they had things like hepatitis C antibody, hepatitis B surface antigen, some sort of history that asked about alcohol. What they did for autoimmune, they had like an ANA, but it's a Kaiser study, and so with it are the limitations that you would get with that type of study. They made the same effort that anyone else in the field made with data available at the time, and since then there's enough other data to suggest that these findings are true. And I like the study design, so I use it to illustrate the point. But yeah, there are problems with the study for sure, if that's what you're getting at. I mean, anything. For example, we used to say that these patients used to be called cryptogenic liver disease, or cryptogenic cirrhosis when they got cirrhosis. Well, we now know that 50 to 70% of those patients with cryptogenic cirrhosis just had fatty liver disease. And so you'll see in a lot of studies when you go retrospectively back to define fatty liver with cirrhosis, you have to take all the fatty liver and half the cryptogenics together, and there are these formulas that people have suggested. So to get at the problem that I think that you're asking about.
Well, what about diabetes and obesity? Separate out those who have those?
No, they didn't. There's a lot of data on diabetes, fatty liver, and progression of other liver diseases, which was definitely not something they did in that study. Because we have, for in transplant or in pre-transplant patients, our Hep C patients with diabetes progress faster than those without diabetes, and get cancer at a higher rate. But this study did not get into that. I think I actually have some data on obesity, diabetes, and prevalence of NAFLD. So why is there a racial or an ethnic difference? Well, this is one of the nice examples of sort of translational medicine where we kind of know the answer to this. So there is the PNPLA3 allele or mutation, which is the adiponutrin gene. And this was a 2008 genome-wide association study essentially fishing for what might be different about these groups of patients that might explain why some people get fatty liver and some people don't. So they came across this allele, and it was a striking finding. So the allele frequency, the mutation frequency, the G allele frequency in European Americans was 0.23%, and you can see here that the triglyceride content in this group is actually lower than in Hispanics. But what's the point of this slide is that those with the homozygous for the G allele had more hepatic triglyceride content than those that did not, and that plays out in Hispanics and in African Americans. But if you look at the prevalence of this gene or this allele in African Americans, it's low. In fact, it's significantly lower than in European Americans, and it's less than half in Hispanics. So it turns out that this probably accounts for at least half of the ethnic differences that we see. And we see this play out in the clinic. We know that Hispanics are at higher risk for progressive liver disease in the setting of diabetes and metabolic syndrome. And we know that despite their predisposition to diabetes, and they do have one, African Americans do not have a predisposition to fatty liver disease. So this was an important finding in fatty liver. We don't use it in the clinic. I don't know how close we are. We've all been speculating lately, will we send this gene? Well, it's not clinically available, and we do sort of wonder if, maybe this is the reason that patient progressed so quickly, but we don't currently use it. What about, so you'll see this was white, black, Hispanic. This was the Dallas Heart Study. This was data from a 2005 study analyzed in 2008. And so there are no Asians. And so it does beg the question, especially for our practice, what's the prevalence of this allele in Asians? Well, it's high. And that gets back to what I was talking about. They are overrepresented. So there have been a number of studies now, these are all 2 and 3 years old, that do show that the frequency of this G allele is higher, 0.3, 0.4, and a little bit higher in Chinese, Malays, and in particular Asian Indians, we know through a number of other studies, are at risk, significant risk for metabolic disease, and because of this allele, fatty liver disease. So what else about the epidemiology of fatty liver disease? Well, I think you can't take care of patients who have obesity, metabolic syndrome, and fatty liver without having seen these slides before. So I'll just show you a few. This is the CDC's record of the prevalence of obesity in the United States starting in about 1986. I've started with 1990 because there's a lot of data missing before that. Now, there's some potential problems here. This is self-reported. Could it be underestimated? It's in the press a lot now, so people are probably a little more aware of where they are on the normal weight, overweight, obese, severe obesity spectrum. But nonetheless, it was estimated that in 1990, no state had more than a 14% prevalence of obesity, and that now no state has less than a 20% prevalence of obesity, and in some regions, it's pushing 33%. In fact, the CDC also says that about 68% of Americans are overweight, defined as a BMI greater than 25, and 35%, so this is actually now outdated, see 2010, 35% of the whole country is obese with a BMI greater than 30. So this is the reason that the prevalence of fatty liver disease is 25%, or 80 million Americans, is because this is a cultural, a systemic problem in and out of doctors' offices. And likewise, 2010 data suggested that, look at these states here. It's the belt across the southeast of the country has a high rate of obesity, and you would not be surprised there's a high rate of diabetes as well, with states pushing 9-10%. I think the nationwide prevalence of diabetes is in the 6 to 9% range, depending on where you are. So that's easy. So let's be a little more specific about, in our clinic, who is going to have fatty liver disease. Who should you be thinking about? Obviously, in my clinic, they usually have the diagnosis by the time they get to me. But what should primary care and gastroenterologists be thinking about as far as who should be screened? So it turns out that in diabetics, and these are two studies in Caucasian Italians, so not Asians, not Hispanic, diabetics have about a 70% prevalence of fatty liver, fat in the liver, which is very high, but not shocking if you think about the insulin resistance, hyperalimentation, obesity that really drives fatty liver and fat accumulation in the liver. Well, these are the patients who had those problems. You can go on and say that in obese adults, there's another study that looked at prevalence of fatty liver in obese adults, 80 to 90%. And then in those going to bariatric surgery, it approaches 100%, which again is about what you would expect. And I talked about the prevalence worldwide and compared it to that in the United States. What we've seen in parallel with our own obesity epidemic is sort of the westernization of world diets and globalization of cultures. And so with that, you see Starbucks in China, which is now the fastest growing market for Starbucks. And 20 years ago, that was McDonald's in India and things like that. And so unfortunately with that, we see numbers now, I say now, but now this is 5 to 10 years old, these studies, that really do show that the prevalence of fatty liver worldwide is the same as it is here in the United States. So you see studies from India that are from below 10% all the way up to 33%. So that's going to fall within, give or take, the 25% range that I quoted to you for here in the United States. Here is the United States range, very similar. We have a Sri Lanka study, and China, and even Brazil. So a worldwide problem, to be sure. But what we see here, and I see a lot of this, is lean fatty liver. So there's lean fatty liver disease is a frightening concept, but still related to metabolic syndrome, still related to metabolic factors. So I see lean fatty liver disease in almost exclusively Asians, and usually older Asian women, who almost always have dyslipidemia with high triglycerides, 200, 300, 400, something like that. And so I think it's interesting that this was published a few months ago in the Journal of Hepatology, looking at not the prevalence, but now this is a more complex study, the incidence of fatty liver disease in a Hong Kong cohort looking over about 47 months of follow-up. They said who developed new fatty liver disease and what were the risk factors for it. So every patient in this study, you'll see here, at baseline had a BMI less than 23 kilograms per meter squared, which I'll show you, is the cutoff for overweight in Asians. It's debatable whether we should apply that to Hispanics, but it's documented that we should apply that to Asians. And so the risk factors were an increase in waist circumference. So that's useful because, again, we use BMI. And if you say, oh, the BMI is 24, done. Well, it's not that simple. If the BMI is 24, but there are changes taking place, turns out that's relevant. And then changes in triglycerides. These two were the only independent predictors of new fatty liver disease in this lean cohort. So why 23 for Asians? This is these slides are borrowed from a fatty liver in Asians talk that I have, and the reason is interesting. So the whole point of having these cutoffs, 25, 30, 35, 40, is to say who's at risk. It's not to, unfortunately, it doesn't motivate patients too well. But you want to say who is at risk for the adverse outcomes of diabetes, obesity, metabolic disease. Well, it turns out that as you gain weight, or as your BMI rises, we'll take Caucasians here, your risk of, this is looking at BMI with diabetes, but you could do the same thing with diabetes and cardiovascular mortality. You could do the same thing with diabetes and stroke. So any outcome will fit this curve. You say, well, Caucasians seem to really hit some level. Their curve goes up around 30, and that's historically why we've come up with 30 or 25. Well, if you look at this risk for diabetes in other races, it's not the same. So it really is, there's some problems with BMI, in particular when you're applying it to other races. So African Americans have a higher risk of diabetes at a lower BMI. Now, I already showed you they don't have the genetic mutation as frequently for fatty liver disease, so they don't get fatty liver disease as much. What about Chinese? And here we go with the Indians or the South Asians. They all have risks of diabetes at way lower BMIs, and so this needs to be accounted for, and that's why we use 23 as a cutoff. Why is that? Well, there's a few reasons for that. One of them is probably the genetic mutation that I showed you, but the other is simply anthropometrics. If you have longer limbs and a proportionately smaller trunk, then you can have a higher BMI that doesn't matter as much because it's not putting you at risk. It's not the central obesity that's putting you at risk. Whereas if you have a smaller frame but shorter proportional limbs and more of your BMI is made up from your trunk, and that's where you put your obesity, turns out these changes do contribute to these differences that we see. So again, just highlighting the difference between Asians and other races and Caucasians. So we have patients with fatty liver disease. What's the natural history of fatty liver disease? Well, we used to think that if you get the biopsy and it showed just the pink slide with the white bubbles in it, that you were probably okay because we called that simple steatosis, and you probably wouldn't progress because you had the benign version of fatty liver disease. That's still mostly true, but what we have now are studies where we biopsy patients with some time in between. There's two studies I'll show you here. One biopsied 6.6 years apart. The other one biopsied, I didn't tell you how far apart, but similar, 5 to 10 years apart. And they said, well, what's happening to these patients? What's the natural progression? So the natural progression in both studies was similar to this. About 40% get worse, about 40% don't, and a smaller proportion, 20%, get better. Now, they weren't accounting for weight loss and treatment and things like that. This is just all comers. And then the other thing that they showed with these biopsies was that fatty liver, or NASH, progresses very similarly to the way we thought Hep C, or the way we think that Hep C progresses, which is 1 stage per decade, give or take. Obviously, there are patients with Hep C who progress faster, and we've all seen patients with Hep C who never progress. Same is true for fatty liver disease, but on average, this study showed that patients with NASH who are progress at 1 stage every 7 years. So that's similar to most other liver diseases. That was the people who already had a little bit of fibrosis on biopsy, but the thing that we learned from this study that makes us go back and rethink what we should do with those 70 million people is that there were those who didn't have any fibrosis who still progressed. Now, they progress more slowly, 1 stage every 14 years. What do you tell a patient whose risk is progression at 1 stage every 14 years? Well, they don't need to see you in 1 year, but they probably need to keep an eye on this, and so it becomes challenging to communicate with patients and primary care physicians on what to do about fatty liver. But the message now is everyone's at risk, but some are at more risk than others. So let's talk about who is at the highest risk. Another recent study that I think is a nice way to illustrate the relationship between diabetes and fatty liver disease looked at 103 patients with diabetes and a normal ALT defined as less than 40. Now, you could say, well, normal ALT for a woman is 19 and normal ALT for a man is 30. But in general, when we see an ALT of 40, we don't think too much of it. We say that's pretty normal, that's pretty close. So they took 103 patients with a normal ALT or near normal ALT, and there's the mean ALT, other characteristics. And they did a proton-weighted MR spectroscopy, which is a really sort of a research tool, a really good way to find fat in the liver without a biopsy. And half of them had fatty liver. So that's, I already told you that 70% of diabetics have fat in the liver, but here is 50% of diabetics that you didn't necessarily think had liver disease. And then they offered liver biopsy to those patients, and 37 accepted, so not all of them said yes. But of those, more than half had NASH. And remember, NASH is the thing that we want to find, and these people would probably not have been sent to a hepatologist or referred because, oh, you have diabetes, but your ALT is normal, so that everything's probably fine. So this emphasizes the idea that ALT is not a very sensitive way to find fatty liver, which is unfortunate because that leaves us without a very good tool.
Did that study also just use ordinary ultrasound?
No. So they took the patients before any imaging, enrolled them in the study, and did MR on every single one. So they didn't miss any fatty liver in this study because MR is so good. But is that what you're asking?
Well, you're not going to use this for screening. It's a research study.
Well, exactly. This is a research study that I'm using to illustrate.
So the question really is, how good is what we do use?
Right. So I'll show you that in a second. So when I'm seeing patients with fatty liver disease, trying to, make an assessment, which is really usually just based on, my opinion or your opinion, who is at risk? Because you'll miss some patients if you set a hard, simple rule and follow it. You'll miss some patients. So what matters? Well, you have to have fat in the liver, and even though I just finished telling you that ALT is not a very sensitive tool, there is some specificity to it. So if you have diabetes and you don't have Hep C or you don't drink and your ALT is 80, then yes, you are more likely to have NASH than someone whose ALT is 30. But I did just show you can't ignore the 30. These are the real ones at risk. Diabetes and or metabolic syndrome. Those are the ones who are really at risk. Absence of alcohol, absence of other liver diseases. And then I put age 50. Age does matter. The older you are, the more risk you do have. It's not been proven that there's a specific age cutoff, and I don't think you should use a specific age cutoff so much as to say, if you see a 30-year-old who has certain criteria, and then you see a 60-year-old who matches the same profile, clearly the 60-year-old you need to take a little more seriously than the 30-year-old.
So are you also saying that simple morbid obesity, since it's not on your list, is not a high-risk factor for NASH, even though it's clearly a high-risk factor for NAFLD?
I am. And let's see, well, let me tell you the study. I'm afraid I don't have it on the slide. So there's a Korean study. So, not all of our patients are Korean, but it was demonstrated in a Korean cohort. Risks for, this is not exactly what you're talking about, but risks for diabetes. And they looked at different metabolic parameters. And the three that were interesting were obesity alone, fatty liver alone, and both. Fatty liver and obesity. And so those with obesity alone did not demonstrate, this was a prospective cohort, I think 7 years, did not have an increased risk of diabetes without any other components of the metabolic syndrome. Whereas those with fatty liver had about a 2-fold risk of diabetes over the period of the study, and those with both had about a 3-fold risk of diabetes. And so the reason I use that example is that I do think that if you truly have obesity alone, I'm not going to say you're not at risk, but I think you're at lower risk than if you have 3 components of the metabolic syndrome or diabetes, and that's why I phrased it this way. Some have referred to those patients as the metabolically healthy obese, and there's a whole literature on that, and that probably has a lot to do with why there are some obese patients who don't get fatty liver or NASH. Now, eventually, if your BMI is 53, eventually your chance of having fatty liver are just overwhelming, and that was shown in those bariatric studies. So I'm going to assume that I don't have that slide and move on because it looks like I don't. So what else do I use to estimate a patient's risk? Who's at risk? What should we be looking for? Because you can't refer 70 million people to GI. You can't refer 70 million people to hepatology, and it wouldn't be appropriate because 90% of them shouldn't be seen anyway. So this is the score that I like, the NAFLD fibrosis score. There's a calculator on my iPhone. There's an online app, or rather, there's an app on my iPhone and there's an online calculator. And the reason it's useful is because it's useful in fatty liver disease, but it also includes all the things that we should be looking for as hepatologists. So for example, age. Age is a risk factor for fibrosis in fatty liver, but it's a risk factor for fibrosis in hep C as well. So age is a risk factor. BMI, yes, we've talked about that. This really gets at the pathophysiology of fatty liver disease. Impaired fasting glucose or diabetes, that's present, that significantly increases the risk. AST and ALT. Now, again, I've mentioned that ALT isn't a great screen for fatty liver disease, but the ratio is very important in determining who has how much fibrosis. And when those reverse, the AST reverses, the AST is higher than the ALT, that's a red flag in patients who aren't drinking or don't have some other kind of drug toxicity. Such that even an AST of 35 and an ALT of 32 in a patient with diabetes should be a red flag, and it's missed more than half the time in the primary care setting because the lab tells people that's normal. Platelets, well, now we're getting into do they have cirrhosis and portal hypertension, so you should pay attention to the platelets, and likewise with albumin. So you plug these in, you get a very awkward result, you have to look it up, but they do have a reasonably good predictive value for those who have no or little fibrosis and those who have advanced fibrosis. And then you have the gray area, and I'll tell you what I think about the gray area in a few minutes. FIB4, this is not just for fatty liver disease. FIB4 has been used sort of as a proxy for fibrosis in many, many, many large studies where there's not biopsy or FibroScan data available. And there are, validated cutoffs, just like with the NFS, using 1.45 or 1.5, and then 3.25 for low, indeterminate, and high risk. Again, not talking about risk of NASH, talking about risk of scarring. You want to know who has the scarring. You don't want to miss them. And then the APRI score, which involves AST and platelet count, turns out that something as simple as this is rather useful in looking at who is at risk. So all three of these scores don't require an additional test. You just have to take 30 seconds and look on your calculator, and so I encourage people to use them. And then we have a test now that can non-invasively tell you what your liver stiffness is. So I took this from, you do a Google search for FibroScan, you get this from some Midwestern center, but again, it says exactly what we're telling patients. Chronic liver disease is common. Not everyone wants a liver biopsy. Is there a way to assess fibrosis without a liver biopsy that's better than what I just showed you? Yes, there is. It's FibroScan. FibroScan, shear wave, MR elastography, all these things are in the same realm of non-invasive tests, but each has, its advantages and disadvantages and its costs. So we use something like this in our clinic to estimate liver stiffness, which has been shown to correlate with fibrosis stage in a host of different diseases, and here at the bottom is fatty liver disease. And it's been measured against the exact scores that I just showed you, APRI, FIB4, NAFLD fibrosis score. I didn't show you AST to ALT, but if you want to talk about a simple score, the AST to ALT ratio alone is about as simple as it gets, and that's been tested. Now, the area under the ROC curve is not great, but it's still been looked at. So, two things from this slide. One, NAFLD fibrosis score and FIB4 are pretty good at estimating F3 or greater. Not perfect, not great. You can't use that and just say book closed, done. But they're pretty good. And then the FibroScan is better. And in this study, FibroScan was very good compared to all of these. Again, the point here is you don't want to miss advanced fibrosis. So you're finding it the vast majority of cases. I threw this in because this is coming to CPMC, and it's coming. FibroScan was approved about a year ago. The controlled attenuation parameter, the CAT function on FibroScan, was approved about a month ago, and it's a tool that will estimate quantitative liver fat. Now, we at the center don't have any experience with it because we haven't yet. They charge you $30,000 to turn the switch on, but there may be a use for it. And so, for example, if the question is, go back to the first slide, you want to find the fat in the liver, and go to the slide I had with the liver on it. You got to have fat in the liver to have fatty liver disease. So most of these patients have had an ultrasound when they come to see me, but how many of the 70 million people have had an ultrasound? Well, it's a small minority. So is there any way that we can screen for fatty liver disease? And the answer is, currently the answer is we don't screen for fatty liver disease because you can't do 70 million tests. But this may shed some light on where we're going. So for example, this slide was taken from we just had the liver meeting, and this was the course supplement. There's a very nice summary of data. I'll warn you, it's heterogeneous, so be careful on how you interpret this. For example, the AUC for ultrasound being this high was to detect a higher amount of steatosis, whereas for all the other ones, it was for a lower amount. So just a disclaimer for this slide. But you can see here that CAP is good. It's almost as good as MRI. Again, they weren't directly compared, but it's pretty good. So we're able to say you do or don't have fat in the liver and how much based on the controlled attenuation parameter. Why might that be useful? Well, there's a CPT code for FibroScan, which is how we're able to, pay for it. And the cost is in the neighborhood of a couple of $100s. So if you start to say, which of these tests might we be able to use on a larger population? Well, if you have 70 million people, probably none of them is the answer because not everyone has a FibroScan. But if you start to look at costs, it's significantly cheaper than ultrasound, which is in turn significantly cheaper than CT. And by the way, you can see here, CT is actually not very good. We don't use CT to look for fat, which is in turn quite a bit cheaper than MRI. So we may be getting a glimpse of the future here, and that these smaller portable machines are starting to allow us to answer the bigger question, who has fat and who doesn't.
Can you help us out and use for that ultrasound line an equivalent, detection that you pointed out? These are mixing apples and oranges.
It is.
And the reason for the question is, what do we routinely use? Ultrasound.
Ultrasound.
And by your slide, if you take it at face value, that clearly shines as the best test.
So I don't know.
Okay.
And that's why I gave you the disclaimer, so you wouldn't ask that question. Here's an abstract from this year's DDW. This is Rohit Limba's group in San Diego, showing basically that looking for fibrosis, MRI or MR elastography is very, very, very good. I would argue as a research tool. Here you have an area under the RC curve that's above 90%. So I've shown you this data. So how do we approach these patients? And so I would argue, and again, this is a conglomeration of a few different things. A recent paper from Liver International and an older paper from Paul Angulo and a presentation at the liver meeting. So the first question is, are you at risk or not? So that's the liver slide that I showed. If you don't have any of those things, then you're not at risk and you don't really need to go down this pathway. And this pathway is my fatty liver clinic. But what if you do? What if you have diabetes, metabolic syndrome? So there are more and more people now who are arguing that you should screen that group. Why? Well, because 70% of them have fat in the liver. And remember, 10% of those with fat have NASH. So now you're looking at a group that has 5 to 10% NASH. That's a significant number, and it's a disease you would want to know about, you might do something about. So the proposal is that in this group, you do the NAFLD fibrosis score. So it seems simple, but what we're asking is that all physicians, all providers who take care of diabetes do this score. And so clearly, that's not being done. The next step is, if the score is high, again, if it's low, the negative predictive value for advanced fibrosis is good, very good. Again, I'm not telling you if they have NASH or not. I'm telling you if they're in trouble. It's just to find the low-hanging fruit. Who has advanced fibrosis? Who's already in trouble? So you can actually take those and say, okay, well, you're not in trouble. Let's move on to those who have an indeterminate score, or a high score, and that would be these patients. The algorithm suggests, and this is one that I'm currently implementing, that those who have the risk and have sort of a red flag should go on to another test, which should still be non-invasive because this is still a very large group of patients. And that those who then sort of opt out, who have a low fibrosis score and a low elastography, again, they're okay. But if they're discordant or indeterminate, then you don't know if they have advanced fibrosis. You don't know if they have NASH, and in fact, they're at very high risk. These are the patients with whom we discuss liver biopsy. Now, I'm not going to get into how would biopsy change your management, because that's where our hepatology training comes in. How would biopsy change your management? If it's not going to change your management, what's the right time to do the biopsy? That's a decision between the doctor and the patient. But these patients could benefit from a biopsy, whereas those who now are found to have a high score and a high FibroScan score, the chances that they have F3 or greater in this study anyway, this one right here, was 100%. And these tests are pretty good. So if you combine these two tests with two high scores, there's not much else that can make those scores high. Now there are some things, a high ALT, for example, could do this. So these patients may not need a biopsy. If they already have stage 3 and you're looking for stage 3, maybe they're candidates for treatment. Maybe they're candidates for clinical trials. Maybe these are the ones that need HCC surveillance, which is an argument that I'll make in just a few minutes.
So while you're getting a sip of water, you made the comment several times that the important thing, you don't want to miss patients with fibrosis. You said
Correct.
that several times. But what doesn't make sense to me, looking at your algorithm, is the real cutoff is who has non-alcoholic fatty liver disease versus who has NASH, which is just the first of a progression on to fibrosis, advanced fibrosis, cirrhosis, hepatoma. Why are you making the break point between NASH and fibrosis versus between steatosis and NASH? Because the lifestyle modification and monitoring you ought to be doing for everybody who has NASH.
So I think I'll answer it this way. I'll say that I wonder if you're referring to the possibility of fibrosis progressing with steatosis without NASH. So that's rare. So the reason I am basically abandoning NASH and going to fibrosis is that they're not universally, but very frequently one and the same. It's uncommon to get enough fibrosis to lead to what this cascade that I've been talking about without NASH, biopsy-proven NASH. We don't.
No, that's exactly my point. You just got, in an earlier slide, said the progression rate is double in those who have NASH versus those who just have simple NAFLD, just steatosis.
Right.
So in your algorithm, you keep, though, going further down the chain, talking about established fibrosis is what you don't want to miss and where you want to intervene. And my question is, why are you that far down the chain where lifestyle modification and monitoring your algorithm there really should be everybody with NASH?
Yeah, no, I agree with that. The reason it's there was to emphasize that there's actually not much else you're going to do for those patients if they don't have fibrosis. Now, yes, there's a caveat. So clinical trials are looking for patients with stage 2, for example. And NASH with stage 2 could be candidates for this. So that's a good point. But again, I'm emphasizing that, what are we really looking for and what are we really going to do? Those with low scores get reassurance, meaning you haven't progressed this far. Yeah, I completely agree that anyone, I'll go one step farther and say anyone with obesity or diabetes or prediabetes should get the same counseling. But there's not much more that I would do for these patients here. And I'm contrasting that with using these tests to identify a much higher risk group, not just higher risk, but those who have already reached one outcome. So I'll have 4 cases that I'll show you that might demonstrate how I would use these scores. So the first is a young Hispanic woman who's obese, does not have diabetes, does not have metabolic syndrome, does not drink, and has near normal ALT. No red flags. She does have this, so she's at risk for diabetes, and she has fatty liver. And so you calculate her NAFLD fibrosis score. Again, these slides, let's say these were, for simplicity's sake, in the days before FibroScan, or if you're a provider who doesn't have FibroScan, doesn't have FibroScan, her NAFLD fibrosis score is low. She's in the low risk group. I would not tell this patient that she needs a liver biopsy. I would emphasize lifestyle modification. And this is probably the patient that you were talking about, John. This patient would be unlikely to qualify for a clinical trial because her risk of, this is very interesting, right? So clinical trials is all about what your biopsy shows if you have stage 1, 2, or 3. So this patient would be unlikely to qualify for a clinical trial, but you can't say yes or no without a biopsy. And I just told you I wouldn't biopsy this patient. So in this slide, I've presented a patient with more risk factors. So this is an older than the first patient, Caucasian man with overweight. There is some insulin resistance here. There is some dyslipidemia here. There are a couple of cutoffs for alcohol use and the possibility of alcohol-induced liver disease. But suffice it to say, the strictest criteria allow men to have 2 drinks per week. And the most lax criteria allow men to have 4 drinks per week. And then for women, the strictest criteria are 1 drink per week, 1 drink per day, 7 drinks per week only. I think I told you the wrong thing with the men too. So men, 14 and 28. Women, 7 per week or 14 in the more lax studies. So anyway, this man is very unlikely to have alcohol-induced liver disease. You have to ask this question if we're talking about non-alcoholic fatty liver disease. The ALT is higher, but the AST hasn't risen. This is not concerning. I put this in here because often we'll get referrals for hemochromatosis for this number, the 88% iron saturation. Turns out that a ferritin of 400 is very closely associated with NASH, and that in fact most patients with NASH have a ferritin that's elevated. Maybe not 800, but when I see this case, I'm not thinking hemochromatosis, whereas some of the referring providers are. This patient is in the indeterminate group. The NAFLD fibrosis score is negative 0.3. You can see that that's indeterminate. And so there's 2 things I would do with this patient. I would say that they also need lifestyle modification because they're at risk. Everyone needs lifestyle modification. But this patient is at higher risk of having the thing that you wanted to know about. And so I would talk to this patient about biopsy. I would say, why don't we see each other in 6 to 12 months? Try to lose 10% of your body weight, or at least 5, and if they come back and they're 3 pounds heavier, then I can say, listen, if you're not going to be able to do these things successfully, then I'm not comfortable not knowing exactly what you have, and that might be a reason to biopsy. Some patients still say no, and that's, at this point, we don't have a lot of options therapeutically. We have vitamin E for non-diabetics. But these are the things that come into play when you're looking at a patient with this level of risk. I would recommend biopsy for this patient. If it showed NASH, I would give them vitamin E, and they would be eligible for a clinical trial. All right, what about this patient? 64-year-old man, obese, diabetes, metabolic syndrome, red flag, AST's higher, red flag, platelets are low. The score catches these things. It's high. And you could use the algorithm that I proposed. You could do the FibroScan. Maybe the score is high. In this patient, there's less question. Do you need to biopsy to show cirrhosis? Let's say that the ultrasound also showed a nodular liver and a big spleen. So now you're not really asking what's their stage. You're saying this patient has advanced fibrosis. You're actually moving on to say there are many patients in whom it's not going to change what you do to show that they have cirrhosis, and this patient may need HCC surveillance. There's no approved pharmacotherapy for NASH cirrhosis. There are antifibrotic drugs in the pipeline. They're not going to be here in the next calendar year. And again, lifestyle modification. This one might be currently the most common reason that I biopsy. So this is an older Asian woman with fatty liver on ultrasound, metabolic syndrome, prediabetes, and there's hypertension in there too. And hepatitis B, E antigen negative hepatitis B, low viral load, and the ALT is 51. So if there was no fatty liver in the picture, this would be sort of an on the fence patient for tenofovir or entecavir. But the problem is, if this patient has NASH, you don't want to treat NASH with tenofovir, and you don't want to treat hepatitis B with vitamin E. You want to make sure you know the disease. So this patient usually needs a liver biopsy. Alternatively, you could say, well, this person's BMI goal is 23, so they probably need to lose 10 or 15 pounds. If they can do that and their ALT comes down, then you've sort of shown, well, maybe this isn't the hep B, maybe it's metabolic related, and you can avoid a biopsy. But as I biopsy more and more of these patients, they have NASH. This is NASH in many of these patients. And so I would biopsy now to determine if they need treatment and which disease needs treatment. And then don't forget that for the hepatitis B, this patient needs HCC surveillance. I think I can go quickly through a few slides here. So I told you from the beginning of this talk that a huge number of people have fatty liver disease, and a small proportion of them have NASH that will progress to fibrosis. So can you just say to most people, well, you have fatty liver disease, it's not the high-risk type, don't worry about it, you're going to be fine? Well, the answer is not you're going to be fine. The answer may be you won't die of liver-related disease, but, and here, John, here's what I was talking about actually. I think it's important to share with patients that fatty liver is probably appropriate to say that it's the sixth component of the metabolic syndrome, and it's putting these patients at risk for metabolic disease and outcomes. So here's the example that I use with diabetes. Obesity alone was a non-significant increase in risk of diabetes. Fatty liver alone was an increased risk, and both was an even higher risk. There have been now 2 studies, both referenced here, that show that fatty liver is a risk factor for death and for mortality. But it turns out that that's not for liver-related mortality. That is for cardiovascular mortality, and it's those same patients that we're looking for with advanced fibrosis. So again, you get to these patients with advanced fibrosis, stage 3, stage 4. Yes, they're at risk, but even that group, which is so big, they're still not predominantly dying of liver disease. They're still at risk for death from cardiovascular factors. So again, even though I'd like to motivate my patients with liver-related data, it's important to sort of see the bigger picture, which is that many of these patients, most of these patients, the fatty liver is not going to cause liver failure. It's going to be a marker for something else. So there are a few recent studies that are looking at the etiology and prevalence of fatty liver disease and liver transplant. So this one looks at patients on the wait list and shows that as of 2013, patients with fatty liver disease are the second largest group waiting for liver transplant, recently overcoming alcoholic liver disease as number 2. This was an older study hypothesizing that eventually NASH will become the number 1 reason for transplant in the United States. Now, there's all kinds of speculation of, how quickly will we see a decline in our hepatitis C transplants, and also how quickly will we see a decline in our hepatitis C liver cancer transplants, because that's a large group here at this center and at many others. And how quickly will this increase? Here's the NASH cryptogenic cirrhosis equation that I referred to earlier. So this author said between 2020 and 2025. No one's gone back and looked at it. I think that's a reasonable estimate, but we'll have to update this, in the next few years and see where we are on these curves. What about fatty liver disease after transplant? I'm showing you a single center study, and I have a slide to follow. So fatty liver disease after transplant recurs. In this study, there were 530 adults that underwent transplant, 12 of them for fatty liver disease, and 11 of them recurred. So fatty liver disease comes back. It comes back because these patients were diabetic before, they go on immunosuppression, and they're diabetic afterwards as well. So recurrent steatosis was present in, sorry. You'll have to just pardon me here. I said 11 of 12. and then 100%. So there's a discrepancy there, but nonetheless, it's very high. And advanced fibrosis occurred in a majority. Now, it's a small study, but it was a majority. They looked at de novo versus recurrent, and de novo fatty liver disease, these are patients who had hep C, alcoholic liver disease, occurred in a majority, but advanced fibrosis in fewer. So these are problematic. These are disturbing. So what do we do with this data? Well, we acknowledge it, but then we say, has it affected the ability of these patients to survive and make use of their graft the way that other patients do? And the answer appears to be no. There's two studies here, 2011, 2014, showing that survival in patients who got a transplant for NASH is not different than survival in patients with other diseases. As you would expect, they're more likely to die of cardiovascular outcomes. And I'm not sure if you'd expect this, but they're less likely to die of graft failure. This probably has a lot to do with recurrent hepatitis C that was studied during the course of these meta-analyses. So what about fatty liver and liver cancer? So I'm going to use this one study from the UK to illustrate a point, which is that diabetes matters. We're seeing more diabetes, and therefore the prevalence of liver cancer and NASH is increasing. This is a single center that looked at referrals for HCC, and they went backwards and said, well, what was the etiology for these diseases? I'll show their data. So they went back to 2000, and they said, how has the epidemiology of liver cancer changed at our center? So this is striking. You see here, there's no fatty liver in 2000, and now it's the largest cohort. Not all data matches this exactly, but it's the same idea in all these studies, that fatty liver is present, it's growing, and it's a problem. The other thing that's interesting here is that 2000 was probably still when we called these patients cryptogenic. And you see here the cryptogenic bar getting lower and lower. But the other problem here is that look at the referrals for liver cancer. It's growing very fast, and we see that in a similar way here in the US. The last slide from the study is looking at characteristics of their patients, and I'm going to use this to demonstrate two things. First, that they actually predicted, and this is obviously a different patient group than ours, but their fatty liver was the second most likely reason for getting liver cancer. Look at that compared to hep C. So obviously very different than ours. But percent with cirrhosis. So we're seeing non-cirrhotic NASH HCC. Here, I looked back a few years ago, and I found that our rate was 10 to 15%. We had 2 or 3 out of 45 cases. That's actually been shown over and over again now. In fact, this is showing more. There's some Japanese studies that show that 40% of their NASH HCC didn't have cirrhosis. And so it's a significant amount. And if you look at this population, now again, this is from the UK, so there's a lot more hemochromatosis. But hemochromatosis, hepatitis B, and fatty liver. And again, what we see are these two in any kind of real numbers, is that we are seeing fatty liver cancer and fatty liver disease without cirrhosis, which has led some to say, we can't screen everybody with fatty liver disease, but maybe we should start screening the stage 3s, knowing that sometimes an F3 on biopsy is actually a cirrhosis. What do you do with your advanced fibrosis? Do you distinguish between F3 and F4? Or do you say, let's lump them all together and call them at high risk? And I would actually favor the latter. So treatment is both very complex and very simple. There is one FDA-approved medication, which I'll tell you about. And we know very well that if you can shed your metabolic risk factors, that you can improve all metabolic parameters, including fatty liver disease. So how does that play out in studies? Well, there has been a study that showed that weight loss does improve NASH histology, but in this study, not fibrosis. There are other studies, and a lot of them are bariatric studies, that show that bariatric surgery with a much larger amount of weight loss does result in improvement in fibrosis and even anecdotally in early cirrhosis. Nonetheless, the cutoff for weight loss and histologic improvement was 7%. And so what I tell patients is if you lose 5% of your weight, you'll probably see your ALT go down, but if you want to really impact the disease, you need to lose 10%, which will easily take you across that 7% barrier. But there are other things that you can do. So Diet. This one study in particular looked at the Mediterranean diet. So this is, changing the fat content of your diet, more protein, less carbs, olive oil, fish, things like that. So they randomized patients to 6 weeks of Mediterranean diet and found that these patients decreased fat in the liver. And you say, sure, they went on a diet, their fatty liver got better, but it was independent of weight loss because they had the power to show this. So even patients who can make significant dietary changes who don't lose weight could be helping themselves. And then in a similar study, patients who can exercise, and this one it was 8 weeks, and it wasn't just heavy exercise. It was moderate exercise too. These patients decreased liver fat in the absence of weight loss, independent of weight loss. So I say, it's not just go lose weight and you can help your fatty liver disease. Yes, that would be nice, but you actually have 3 things that you can do. You can lose weight, but even diet helps. And the exercise component helps. So it allows you to sort of stress these things individually. I'm only going to give you one slide summary of the Pivens trial. The Pivens trial was a randomized trial looking at three treatments. One was placebo, one was vitamin E, and one was pioglitazone. 247 patients, about 80 in each arm. And even though pioglitazone and vitamin E both helped liver enzymes, only the vitamin E actually significantly changed our research tool, the NAFLD activity score. Based on this, vitamin E was approved for the treatment of biopsy-proven, non-diabetic NASH. So you can see there's some restrictions on the utility of vitamin E. It's probably very helpful for some people, but there's been an association shown between cardiovascular outcomes and vitamin E. So do you want to be giving vitamin E to patients who are already at risk for cardiovascular events? They took sort of the safe route and said, no, we're not going to recommend that. And neither lowered fibrosis. So again, it's all about the fibrosis. We have vitamin E. This study allows me to tell some patients they could benefit from vitamin E, but I never mention it first, so that I don't risk them saying, oh, I'll take this pill and my liver will get better, because it's probably not that simple. Obeticholic acid, which is a synthetic bile analog for the farnesoid X receptor, has been shown to improve fibrosis. And so the company that makes this drug got a lot of people's attention when these results were released. And I didn't go into the nitty-gritty detail, just to show that this drug actually does what we need a NASH drug to do, but it does a couple things that we wish it didn't do. It causes pruritus. Now in the PBC study, it caused twice as much pruritus, but that's because the baseline pruritus in PBC is much higher. But still, a significant amount of pruritus. That's not why it didn't get approved, though. It didn't get approved because it lowered HDL and raised LDL, not by a lot, but by a statistically significant margin. And the FDA said, we need to look more into this before we can give this drug to all these patients who are at metabolic risk. And so now there is a phase 3 trial that we will have within a month or so here, looking at NASH with fibrosis and obeticholic acid. So I'll summarize with 4 points. NAFLD is the 6th component of the metabolic syndrome. Consider screening those people at highest risk for fatty liver disease. 10% of those with fatty liver have NASH. So again, I told you a few things about that. Number one, that's a lot of patients. Number two, this is probably not the message we should be telling patients with diabetes, that, oh gosh, you're at risk for cirrhosis. That's not the message. I think you're missing an opportunity if that's what you tell them. Nonetheless, we do know that all of them are at risk, some at lower risk than others. Remember, 14 years for those without fibrosis, 7 years for those with. Liver transplantation remains an option for patients with NASH cirrhosis, and even though they seem to have recurrent disease, it has not appeared to have an effect on their survival. And we measure 1, 3, and 5 year outcomes, and they have done statistically just as well. So we continue to offer liver transplant to these patients. And lastly, my message would be that lifestyle modification is still number one. There are some patients who could benefit from vitamin E, there's a drug that is close that may benefit a larger group, and there are many other agents that may improve the pathophysiology of disease, but they are not that close. And so with that, that's my last slide. I'll say thank you, and if you have any questions, I'll be happy to take them.